Hi, my name is Elizabeth Cantu, and I'm a student physical therapist at the University of Texas Medical Branch. And I will be speaking about my experience at my first clinical rotation, a grant site, and the role that interprofessional played in my day to day. So I had a 10-week acute care rotation at DTAR Hospital Navarro, located in Victoria, Texas. I was predominantly ICU, with my first 5 weeks heavy in the COVID ICU, given the high incidence of cases in the area at the time. Uh, to give a better idea of Victoria, Texas, it is an area heavy in agriculture, but also the hub for neighboring towns, given that it is considered a more urban area in relation to the nearby rural towns. So, considering the patient population that I predominantly worked with, my patients range from early 40s to 90s. So I did work with older adults predominantly. Concerning the medical diagnoses, it was predominantly COVID related, but I did have some patients um, status post a coronary artery bypass graft or some other heart related procedures. There were a couple amputations secondary to uncontrolled diabetes, with which these patients, they were aware of their diabetes, but did not have the sufficient resources for medical management, and really only came in when their wounds or ulcers wouldn't heal, and it was just so severe that the only option up to that point was amputation. Did have some patients with strokes, although there was no vascular neurologist on site, but we did have a telehealth system in place for that. There were also elderly patients who came in with altered mental status, majority of the time due to a UTI, and then some less common ones like a snake bite or stab wounds. Very common comorbidities seen were hypertension, diabetes, and some diabetic neuropathy, hyperlipidemia, peripheral arterial disease, chronic kidney disease, chronic obstructive pulmonary disease, and dementia. So, in my day to day in acute care, interprofessionalism collaboration was a crucial part of my prep process that my CI Audrey Kilgore instilled in me from day one. Aside from our daily chart review before going to see any patient, eval or treat, we would speak most oftenly to the nurses on staff. Pictured here is actually the nursing station in the ICU at DTAR, which was a key information hub for me. In the small whiteboard pictured here on the left side of the picture, I actually have the nurses' names and on that shift and which rooms they had. So I would track the nurses I needed to talk to if they weren't already at the nursing station, and just kind of get a rundown of my patient. Being in acute care, patient status fluctuates so much so that even though I may have read the latest note from the nurse earlier that morning, later in the day it may have changed. And nurses had really good information on how the patient was doing, how did they sleep the night before, what was their mood that day. Maybe the doctor was planning on removing a chest tube. Maybe they were having to have scans later that day. Just things like that that are just kind of pertinent for me to know, just to kind of get a better idea of what I'm walking into, kind of what's going on with this patient. And also, it was just very important for me and the nurses to be on the same page. Sometimes the nurse would ask me to speak to the patient because they just really weren't listening about how important it is to get out of bed when they were able to, because either the patient refused to or didn't think it was safe. So many times, just being able to offer that education to the patient so they weren't just hearing it from the nurses was huge, and the nurses really appreciated that. So again, if the nurse had just a particular goal for the patient, I would make sure that I was able to help the patient accomplish that, if it aligned with what I had planned as well. It was also just good just to build the relationship with the nurses. They spent so much time with the patient, and being able to help them whenever they need help, they appreciate it greatly, which really does pay off. And during my time there, I created some pretty great relationships with the nursing staff. Also, being in the COVID ICU, respiratory therapists were all over the place. So I did speak with RTs quite frequently just to get, current update on just the patient as a whole, if they were being weaned off of oxygen. Sometimes they would give me a heads up like, hey, we did change their or lower their oxygen flow, so they may be a little bit more out of breath when getting out of bed, so not to be alarmed. So things like that was kind of crucial to know. Also, we did speak with OTs. We did have the same patient sometimes, so we would speak about that in the morning. And if maybe a patient was more complex, we did speak about a co-treat, which I will be speaking about next. And then less commonly, but still happened, I did get to speak with nurse practitioners and MDs, whether I had questions for them or vice versa. And although not technically interprofessionalism, there was a constant communication between the PTs and the PTAs in the morning and during our lunch breaks. The patients were just shifted around so constantly between the whole team. It was just good that we were able just to kind of have a little powwow of just a rundown of each patient and making sure that everybody was on the same page. It was just quicker than having to thoroughly go through all the charts and notes, and sometimes it was just quick just to get some good information out of whoever had worked with the patient the day before or earlier that day. So here is a patient case over a co-treat that I did with an occupational therapist at DTAR. We had a patient who was an 89-year-old female with a medical diagnosis of a myocardial infarction, fracture of her left elbow, and was COVID positive. Patient was alert and oriented ×2 and was pleasantly confused. She had a tendency to ramble about random things and needed questions repeated to her multiple times for her to understand. And prior to us entering, the nurse had a hard time getting the patient to understand why she couldn't put any weight through her left arm. She was alone when she was admitted and could not accurately recount any pertinent subject information. So while I began the assessment, the OT was actually on the phone with the patient's daughter, getting just pertinent patient history that the patient was not able to recall. So through that, we were able to find out that a few days prior, the patient had a fall late in the night. She lived at home by herself, used a walker at night and a single point cane in the day, and when she got up to go to the restroom, she had fallen, was not able to get up on her own until the next morning. Her daughter had found her the next morning when she went to go visit. They took her to the hospital. She was scheduled to have surgery in Houston, but they couldn't get her in because she was found to be COVID positive, so they sent her home. From there on, her daughter took care of her at home, and that is where she noticed that her mom, who was independent before, was able to cook and clean and mow the lawn, was now not able to get up on her own, was having issues eating, was not drinking, and was just very weak and debilitated, which was very unlike her usual self. So they had sent her to Edna, where they found that her troponin was elevated, and then transferred her to DTAR. So from there, all that information that we had gained was very important, and we couldn't have done it if we weren't able to contact her daughter, and with myself being able to keep an eye on the patient and able to begin my physical assessment, the OT was able to get good subjective information that was pertinent for the both of us. So between the OT and myself, we were able to obtain the full assessment while being safe and efficient throughout the whole time. So with this interprofessional co-treat, there was just less redundancy. We were both getting the same information that we needed from the daughter that the patient was not able to provide. It was just a more efficient evaluation as a whole. The patient was just very confused, and it was very hard for her to understand instructions. But between the both of us, we were able to efficiently conduct our evaluation to the extent that we could, while the patient was safe and maintained her non-weight-bearing precautions on her left upper extremity. And afterwards, it was great just to be able to collaborate on the plan of care for this patient, given that she did have a lot of things going on and this newfound confusion was not the norm for her. So to discuss just the impact of interprofessional care and just its relevancy, it was just an invaluable experience as a student, and not only being on a rotation in general, but being able to collaborate with other professions and speaking on patient conditions and just being able to foster respect and communication among health professions was huge. Through that, I was just able to incorporate a collaborative healthcare approach that I can then incorporate as a future clinician, and just the knowledge that I gained through interprofessionalism is something that cannot be taught in the classroom. And thank you for listening to my presentation.